everyone. Welcome to this webinar, the first webinar of the year from the Center for Development Economics and Sustainability at Monash Business School. Today's webinar is on the rollout of COVID-19 vaccines, emerging experiences and issues. This webinar is part of our ongoing series, COVID-19 and beyond. We started from last year in May, and we have since been going. We have organized many webinars focusing on many issues related to the ramification and responses to the pandemic. And our last webinar was, speaker was the Nobel laureate Joseph Stiglitz. Before we start this webinar, I would like to acknowledge I would like to begin by acknowledging the traditional custodians of the land on which our 4 Australian campuses stand and pay our respects to the elders past, present, and emerging. So today's webinar is a very important topic on vaccination. We all know that countries around the world are now racing to vaccinate as many people as fast as they can, but vaccination for all people is a huge task, and it raises an important issue, several important issues, including distribution, logistical challenges, role of government, and vaccination hesitancy. So the incentives for governments are also clear. The more quickly you can vaccinate, the more people can be, more lives can be saved, and economic recovery can be quicker. But this also means that we also need to think about not only ourselves, but also people in the region or border or around the world. So we need a kind of international cooperation on this issue. And we already have seen the vaccine diplomacy has started. India, for example, is giving vaccine to many countries free, or sometimes using its vaccine development capacity to make friendship with other countries. China is also doing the same way, giving vaccines to Indonesia as well. And many countries are also relying on the COVAX initiative. So we will also need to think about how the rollout is moving on across the countries, and we will learn lessons from our expert panelists. And today's webinar will be moderated by Professor Karin Leder. Karin is an infectious disease physician and currently head of the infectious disease epidemiology unit in the School of Public Health and Preventive Medicine at Monash University. She is involved in diverse areas of clinical and public health infectious disease research. She has published widely in academic journals and wrote many book chapters. She currently holds an NHMRC Senior Research Fellowship, and in 2018, she won the Frank Fenner Award from the Australian Society of Infectious Diseases. So before I hand over to Karin, so just to inform you that today's discussion will be followed by a Q&A session from the audience. So please send your questions via Q&A function in the Zoom, and we will try to get back to your questions towards the end of the webinar. Over to you, Karin.
Thank you very much, Anna. So thank you so much for inviting me to moderate this panel. And welcome to the panelists. Well, there's been just so much said about COVID and COVID vaccination over the last 12 months, hasn't there? And I think it's really, as we just passed the 12-month milestone of this global pandemic, it's really fascinating to be reflecting on how far we've come on understanding the virus, how it's transmitted, how it presents clinically, how we can diagnose it optimally, how we can treat it, and now turning to how we can prevent it with vaccines. And I'll admit that I was a skeptic when people were saying that we'd be rolling out vaccines in 2020. I thought that that was overly optimistic in terms of timelines. but it's, I guess, a perverse issue that we found in a way that the dramatic outbreak that we've had globally allowed us to get through the clinical trials in a really rapid period of time, because when you're rolling out vaccine trials and you want to assess the efficacy of the vaccine, you need to have enough cases occurring, enough people exposed to be able to determine efficacy endpoints. And as I said, it's because of how dramatic the outbreak has been that we could reach conclusions about the vaccines in warp speed time. I'm sure many people have heard about the fact that there's a variety of different vaccines that are being rolled out and are being studied. There's two traditional vaccine platforms that we have a lot of experience with using for other vaccine preventable diseases, namely inactivated vaccines and also protein subunit vaccines. And in the COVID space, we have inactivated vaccines such as China's Sinovac vaccine and the vaccine Covaxin, which are being used. We have the protein subunit vaccine that's undergoing trials that's manufactured by Novavax. And then we have two more novel vaccine platforms that are also rolling out COVID vaccines. So the first of these, and again, I'm sure most of you have heard of this before, but we have the nucleic acid vaccines, or RNA or DNA vaccines, which essentially provide our own cells with the instructions on how to make the relevant protein antigens against COVID, against the COVID-19 spike protein, so that our immune response is stimulated and primed to produce antibodies and to be ready to fight the vaccine virus, the COVID virus, if and when we're exposed. And they're the Pfizer and Moderna vaccines that have emerged and front runners in the vaccine races that work in this way. We also have the viral vector vaccines, which do a similar thing in terms of getting our own cells to produce antigens, to produce the proteins against the COVID spike protein. But the delivery into our cells works in a different way, and works instead by linking the COVID-19 antigens to a harmless virus, and different viruses are used, but for delivery. And the examples that we have are the AstraZeneca vaccine, the J&J vaccine, which was just licensed in the US, China's CanSino vaccine, and there are others. And in addition, there's numerous other vaccines in the pipeline. And it's hard to keep all the different vaccines and the different types of vaccines, in your head. And there's new vaccines that for which trials are emerging, so rapidly. It's also an even busier landscape, because as the vaccines are rolling out, we're starting to look at how different combinations of vaccines can be used. And there's pros and cons with any of the with all the vaccines that are available, in terms of the ease and the cost of manufacture, how they're stored, how they're dosed, and how well they work. But remarkably, all really seem to be safe and seem to be able to prevent severe disease and death. So I think one of the fascinating things I'd like to explore with the panel this afternoon is, in this landscape of so many different vaccines, to individually discuss how things are playing out in the context of the local context of our three speakers. We're going to be able to hear about perspectives from Australia, from Raina McIntyre, from Indonesia, from Dr. Pandariono, and from India, from Dr. AJ Shah. And I think hearing the individual stories of the controversies and the successes will really bring some of the vaccine issues to life. We're in very different stages of the epidemic across the 3 countries. Australia's had under 30,000 cases and under 1,000 deaths. Indonesia's had the official case numbers about 1.3 million and about 150,000 deaths, whereas India's over 11 million cases and over 100, Indonesia, about 30,000 deaths, and India about 150,000 deaths. So very different spaces, yet all grappling with similar issues in terms of vaccination. The way that we're going to run today's session is to have our panelists be asked a series of questions and give each panelist some time to respond. We've got a number of issues that we'd like to get through, but as some said, we'd also be really keen for people to put any questions through Q&A, and we'll try and get to them towards the end. So now to introduce the 3 eminent panelists. Professor Raina McIntyre is from the University of New South Wales, where she's a Professor of Global Biosecurity. She also heads the Biosecurity Program at the Kirby Institute, and she leads the NHMRC Centre for Research Excellence in Epidemic Response. If I went through all the many things she does, we'd be using up our whole time, but really Raina, with the specific interests that she has had prior to this outbreak and through this outbreak involving PPE, vaccinology, epidemic response, and emerging infectious disease threats. She's been eminently qualified and a clear voice at the centre of the Australian COVID response. So welcome, Raina. It's a real pleasure to have you on the panel. Dr. Pandaryono works in the Faculty of Public Health at the University of Indonesia. He also has a long list of prior roles, including working as an international consultant for UNICEF in Thailand and working for the WHO. His background, or a lot of his work prior to COVID, involved TB and HIV, but he's now added COVID into his schedule. And he's been a strong public health voice in Indonesia. So it's a real honour and pleasure to have you on the panel, Pandu.
Thank you.
And Dr. AJ Shah is a research professor at the Jindal Global University in India. AJ has had so many different roles and experiences, including serving as a professor at the National Institute of Public Finance and Policy and as a consultant to the Department of Economic Affairs at the Ministry of Finance in India. He engages in academic and policy-oriented research at the intersection of economics, law, and public administration. And I'm so interested in hearing your perspective on vaccine issues in India. So, first question that I'd like to pose to the panel, and we might go to Raina first, then Pandu, then AJ for this question. It would be great if you could just give the audience some background as to when vaccination started in your country, which vaccines are being used, and who's being prioritised for vaccination.
So the vaccination program started at the end of February, and the first vaccine so the Australian government had arranged contracts with several companies, including Pfizer, AstraZeneca, and Novavax. The first one to be approved was Pfizer, and that was also the first one that was available. The AstraZeneca has now been approved as well and has arrived in the country, and I believe will be available from next week or soon after. There's a series of a tiered approach to prioritization. So the highest risk are those who are either at high risk of getting infected or at high risk of potentially of complications, and that's the healthcare workers in specific specialties like intensive care, emergency, also paramedics, and hotel quarantine workers, So we do have a international border closure, and anyone coming in through the borders has to go through 2 weeks quarantine in a designated quarantine hotel. And that's where most of the cases that we're seeing are arising, and occasionally there's been a leakage into the community. So that's a real point of focus. And then the 1B is people who are at medical risk, like older people over 85 first, and then over 75, and then over 65, people with chronic diseases, Aboriginal and Torres Strait Islander people, and other people who are immunosuppressed and so on. And then it goes down from there down to the last priority group, which is healthy younger people, which is quite different from the approach to Indonesia, which would be interesting to hear about. But we do have an aging population, so that's a consideration in terms of the prioritization. I mean, the other consideration for Australia is we've got no community transmission. So we're living in a relatively COVID-free environment, which makes decision-making different and not as pressured as countries that are experiencing substantial community transmission.
Fabulous. Thanks, Rana. Andrew?
Okay, thank you. Indonesia started vaccinations during February, and the first priority is among health worker between 18 until 59, and because they are using Sinovac Coronavac, it means that the available vaccine in Indonesia is Coronavac. And when we realized that we forgot the most important age group among health workers, is when the older health workers also should be immunized. And then we're trying to fight to do the elder health worker that's still active, provide health services. And then now become currently the priority is become, the first priority is health worker and elderly between more than 60. It means that this is the current wave for the first wave. But before we finish the first wave, we already started the second wave. The second wave is the traders, also the public office worker. It means that the teacher and also the police and the military and the parliament member. It means that mostly it's become very confusing most of the people, because we not finished yet in the first wave for the health worker and also for the elderly, and then we overlapping with another group that make the controversial between in the country. And we priority the big city. The only city that we priority is only in the big city, in the 34 including Jakarta, 34 province, and we not yet go to another area. It means that because our stock of vaccine is still limited, and currently we still waiting for another vaccine, available vaccine, and maybe for the COVAX facility will send to Indonesia this month or next month, will be arrived in Indonesia. It means that another controversial is the issue about the another vaccination for private. The privates want exclusive vaccine because they want to do the vaccination by themselves. It means that they want to do the vaccination among the private employee, because they want to start the economic activity by doing the vaccination for employee. And it means that another problem that we facing about the vaccination, and this is the current situation. And then we try to persuade the governments not reaching the herd immunity, because if you want to do the herd immunity, it means that you should vaccinate more than 80%. It means that 180 million people should be vaccinated in this 1 year. The President Jokowi want to do finishing in 1 year, and the Minister of Health is impossible to do the 1 year. It means that our team in
Andrew, I might stop you there because we're going to talk a bit more about the rollout moving forward.
Okay.
But AJ, I wonder if you could give us a bit of just tell us about which vaccines India is using and who's been
CoronaVac using we only one vaccine available, CoronaVac, Sinovac, and this is already also produced in Bio Farma in Indonesia.
Great, thank you, AJ.
In India, there are two main vaccines that are in play. As you may know, there is a firm that is called Serum Institute in India, which is one of the world's great manufacturers of vaccines. It is the world's largest single manufacturer of vaccines. And they had a contracting arrangement with Oxford for the AstraZeneca vaccine, which in India is being called COVID Shield. So that is one main candidate that is in fray. And there is a locally developed vaccine that is called Covaxin. So these are the two main vaccines that are in play. In terms of the logistics and the rollout and the prioritization, what's being done is a completely centrally planned government thing, that the government alone has vaccine supply. And it was rolled out first to healthcare workers, then to older people. Right now, it is being rolled out to older people. This whole thing started a few weeks after the vaccine rollout, say in the United States or in the UK. And it will open up further starting from later this March, and we'll talk about it further as we go.
I might stick with you, AJ, to go to my next question, which is, we hear in the media and when I read articles about the different controversial issues that have arisen in each country as they've thought through which vaccines they're going to roll out, how they're going to do it, who's going to do it, which is the best vaccine, has there been enough testing of the vaccines? I wonder if you could tell us about some of the specific issues in this kind of, or the specific controversies that you've experienced in India.
There are 5 controversies that have happened in India. The first is the question of vaccine approval. So there was an approval given to an Indian company to make to push the vaccine out into the public domain, even at a time when their data was not released, when their papers were not published. So that made people very nervous. Similarly, approvals have not been given, for example, to the Pfizer vaccine, okay, which frankly doesn't make sense. So was there a politicization of approvals? Was there nationalism in the approvals process? This is a controversy number one. Controversy number 2 is about the extent of government control and government management of the entire vaccination effort. Now, the Indian state has low state capacity. As an example, if you think of the simple standard vaccines that are given to kids, the vaccine coverage is between 60% and 80%, depending on how you want to think about it. So we're nowhere near comprehensive vaccination of kids for a standard batch of vaccines. And there is no formal system for adult vaccination. In that environment, there is a controversy surrounding the extent to which the government has controlled, has monopolized the vaccine story. In fact, between 60% to 80% of healthcare in India is done by private persons. And would it have made sense to just allow a decentralized market-based mechanism for the vaccines to spread out all over the country? There could be funding by the government, but did there need to be intimate management by the government? The third problem is about information. So there is a vaccine hesitancy problem, which has been fueled by difficulties in the approval process. And in India, we have a unique problem, which is what we term as information hesitancy, which is where the people don't like their data being with the government. So there is a lack of checks and balances. There is a lack of privacy law. There is a great deal of data that is being captured by the government. This also happened with a mobile app that was sought to be used to do contact tracing. And there was an uproar about privacy problems associated with that app. And similarly, there is a app which is being used to handle the vaccine rollout. Once again, it's a single government owned app, and there are concerns about the functionality. There are concerns about whether the app works correctly. There are concerns about leakage of data going into unintended applications by the government. So these are the concerns that have arisen in India.
Raina, what about in Australia?
Well, I think, in terms of anti-vaccination, we've got about a 2% rate of fixed anti-vaccination, which has been constant for the last 20 years. And I don't think that's changed a lot. We've done some research looking at hesitancy, and, there could be up to 20% of people who have some hesitancy, but not about any fixed kind of issue, which means that they would be open to health promotion and communication and education. And it's important to get that group of people who are hesitant with the right kind of communication. Other than that, I think the only issues have been about the storage and of the Pfizer vaccine, which requires, minus 70 degrees. And that's been a concern, in terms of how it could be used in particularly remote and rural areas. But I think in general, there've also been a number of studies looking at trust in government, and it's quite high in Australia. Most people tend to go along with public health programs, and we don't see a lot of. We did have an anti-vaccination protest in Melbourne, I think, but there was only about 100 people there, so I don't think it's a huge issue.
And Pandu, what about in
Okay. Indonesia, I think the problem is a lot, but I will categorize about the hesitancy. The hesitancy in Indonesia based on the social political situations, that the proportions to wait or to reject or to want, they waiting for the vaccinations in the area that where the Jokowi is lost during last elections, like in West Sumatra, like in Aceh, provincial. It means the political situation in the last history still maintaining between the polarization between pro Jokowi or pro not like Jokowi. It means this is the first situation about hesitancy. Another hesitancy about the halal, because 80% of Indonesian is Muslim, that if you get only approval as efficacy, not approval from the Islamic religious leader, it means it's very difficult to be accepted as the vaccinations. The only vaccination in Sinovac is well organized to do the process, both of the process, the process approval for scientific approval, and then for halal certificate approval for that make the vaccination acceptance is okay. But for another vaccine that will be waiting for approval is not yet ready for approval for the halal. It means they have still, we will facing difficulty to accept the vaccinations in Indonesia. And the second is our vaccine, current vaccine is a moderate efficacy. Like Sinovac is only 60 or 70% efficacy, that is impossible to reach herd immunity, only 70% of people to be vaccinated. It means maybe 100% more than, at least near 100% to be vaccinated. It's make difficult to get the achieving level that we want to do for controlling the pandemic if we want to the objective still herd immunity. And the third is about the infrastructure for to do the vaccination, because our country is big and the population spreads around the islands, and we have difficulty about distributions and also the vaccinator itself. It means that it's not easy to implement the vaccination in Indonesia.
And I'm going to prompt and ask about another controversial area that I've read about, which is the government's, from what I understand, mandating the vaccination.
Yeah.
Or can you just tell us a little bit about that?
Yes, and also because the government is afraid about the maybe it's very difficult to achieve, and they make regulations. The regulation about mandatory vaccinations, and they will fine or they will lose of the social support from governments like Bansos, it means that or in Jakarta itself, there is fine for the people who reject the vaccination. It means that it is not helpful actually, because the government, the people, like, why we should vaccinate if you think this is good for us, why you should put another pressure among us? Just educate people that this is good for us and helping another people. It means that this is controversial also become the big issue in the next when we roll out to the public for the vaccination.
Do you know, is vaccine hesitancy, is it so far been a problem, and is it, and what's it, how is that being managed in India?
It is a significant problem. One of the surprising discoveries is that 40% of healthcare workers are not taking the vaccine. But so far, there has not been a systematic effort at trying to combat this, and mercifully, there is no compulsion by the government.
Pandu briefly touched on the issue of public versus private supply and costs. Raina, do you just want to give a summary of how that's working in Australia?
Well, at the moment, the vaccine program is publicly funded, but there's partnerships for the rollout. So, for example, the aged care rollout initially was in partnership with some healthcare agencies that normally provide surge capacity for clinical workforce. But we're now using Australian Defence Forces to try and help with that rollout. So that's a mixture of public and private, I guess. Eventually, pharmacists will be vaccinating as well, and obviously that's private enterprise. That's the intention, I believe, as well as general practitioners who are also private.
But the vaccines, the government's made a commitment to provide the vaccine for free to everybody, correct?
Yeah.
In turn. What about in Indonesia, Pandu? How is, you started to talk about this before, but how is this impacting on the likely costs and potential for rollout?
Yeah, it means that actually the private asking permissions to not only provide vaccinations among their employee, but also they asking the permission to sell the services, because if many people doesn't want to waiting in queue in the public services, they can jump to the private services by paying something. And this is many people doesn't agree, because it means that the vaccinations is should be prioritized, and then somebody who have power, especially money, they should not wait. They can jump to good, easily get vaccinated. It means that this is about inequity, about in vaccination in Indonesia, because the only people have power, have money, they don't need to have the government vaccines, and they have specifically different vaccine from governments, maybe the Pfizer or Moderna or any the high price or high efficacy vaccine. That's it means that still controversial. Indonesia is still under debate and discussion now.
And AJ, what's the situation in this regards in India?
So as I said, the dominant force in healthcare in India is the private sector. And the private sector has the ability to carry this out on scale. And so far, the government system has blocked the private sector from doing anything in this field. As I said, as an example, the government has not given the permissions for the Pfizer vaccine to be used in India. So imagine if there was a private person who was willing to pay money to a private healthcare provider who was willing to pay money to import the Pfizer vaccine. But the government is using its coercive power and blocking that. So I feel that there are important concerns about how this is impeding the scale and outreach of vaccination all over the country, because public systems are relatively small and ineffective, and we will not be able to get a whole lot done by working in the public system. There is some talk right now about opening up to private players, but now the government is saying that they will have a price cap. They will not allow a private healthcare organization to charge a customer something based on market forces. And here again, I feel this will simply reduce the extent to which we get vaccination done. So my worldview is just get people vaccinated. And we should do whatever it takes. We should get more and more people vaccinated. We should stop worrying about who pays how much. If there is any way in which more people can be vaccinated, we should do it. So there should be a public system. So there should be a public rollout where the vaccine is free, but the public system is limited. And if there are private people who will put their shoulders to the task and let market forces work out, there will be competition. The price will be determined on the private market. It'll get more people vaccinated. It'll get us closer to herd immunity. I think that is sound public health policy, but that's not where we are in India today.
It's interesting, isn't it? Because the perspective that we would have in Australia, where it's all happening publicly, I think, Raina, you can correct me if you disagree, but I think if there was a private market, we'd consider that an opportunity for queue jumping, so that you could potentially, move up into a tier to get vaccinated earlier, and therefore it might be inequitable.
Yeah, I just like to reiterate that these things are contextual. You've got to see it based on the conditions around you. If I was in Australia, I'd be singing a different song. I am here in India, where on a modest sized standard immunization program for kids, we get coverage of 60 to 80%, where 60 to 80% of healthcare is private, where there is no public system for adult vaccination. Now, in that environment, how do you reach out to 70 to 80% of 1.36 billion people, which is what is required for getting to herd immunity? So I feel we've got to be pragmatic. We've got to solve problems in our backyard. This is the world that we see, and we should be asking ourselves, what would be the most effective pathway to herd immunity?
Raina, did you want to add anything more?
About the sort of queue jumping private availability? Yeah. I think that is a concern, and it's especially important that the highest priority people get vaccinated first. And I think that's the approach Australia is taking. I suspect by the end of the year, we will have vaccine available on the private market, especially as more and more vaccines become available, or sometime next year.
I think it's just fascinating hearing these different perspectives, and it shows that we are linked globally by all of this, but we really all are having our own epidemic and our own issues to deal with. We've touched a bit on the issue of vaccine efficacy and what the trials have shown and where the trials have been at when the licensing has occurred in the different contexts. And I think, you know, when we look at the different clinical trials, that there's some, I guess, high-level simple messages about, you know, the ones that the terminology was the most effective, you know, the mRNA vaccines. But there really has been differences in who's been, some of the populations that have been studied and the endpoints that different trials have looked at. And now we're also being faced with different circulating vaccine viral variants, which are changing, you know, changing some of the landscape of how well we think the vaccines are going to work. So perhaps this is the million-dollar question, and I might throw to you first, Raina. But in this setting of increasing emerging variants of concern, how do you see the efficacy of vaccination as a tool to impact on COVID endemicity and on any kind of return to normal?
Well, it's a challenge because there is reduced efficacy, particularly to some of the variants of concern, like the South African variant, a little bit to the British UK variant, but not as much. That's not an insurmountable obstacle because any vaccine can be adjusted to match the a variant. In fact, the vaccines, most of the vaccines that are currently being developed were actually developed to the original Wuhan strain, which kind of died out and was replaced by this D614G strain, which was dominant for most of last year. But the vaccines are still effective against that strain. So the question is how quickly we can match vaccines. The mRNA vaccines can be done, the process is quicker. Some of the other vaccines may take 9 to 12 months to adjust. But if we get really high vaccine uptake, then you kind of reduce that selective pressure for emergence of new mutations because there's less circulating virus. So I think that's the big picture aim, is to vaccinate as many people as possible so that we reduce the circulation of the virus and thereby reduce the selective pressure for mutations to occur. Otherwise, it's going to be just like playing whack-a-mole. You know, we'll be consistently just chasing these mutants and never catching up.
Sorry, in terms of when we talk about vaccine efficacy, I think we need to qualify what endpoint we're actually referring to, because anyone please correct me if I'm wrong in your local context, but in terms of preventing hospitalisation and death, you know, we're all the vaccines are actually have been remarkably effective, and we're now starting to see some of the observational real world, you know, rollout data, which it seems to be supporting that, particularly once you've given a couple of weeks for the immune response to develop after giving the vaccine. You know, the rates of protection from that severe disease are incredible and almost 100%. The difference that we're seeing, or the difference that we talk about with the mRNA vaccines being up around 95%, and the AstraZeneca vaccine, for example, and the vaccine that's being rolled out in Indonesia being more, you know, 60 to 70%, that endpoint is has varied a little bit, but has generally been how many people have been found to have symptomatic infection. What we really want to know to get to herd immunity is, can we stop infection altogether so that we can stop transmission? And Pandu, you raised this as an issue before. You said that you think that community is a bit put off by some of the vaccines by hearing about the other vaccines that are available. Is that the message that's kind of getting out there, that it's you've got the bad vaccine, not the good vaccines, rather than the messages of it saves life, all these vaccines save lives?
Yeah, it means that many people believe the vaccinations can prevent the infections. Actually, the wrong message already accepted by many people, even by political leader. It means that vaccination they consider as game changers. If you got vaccination, we will go to normal life. Actually, it's not easy like that because our vaccine just protect for the become severe cases or protect for the death. It meant that immune response itself is very difficult to be measured actually, because there's so many factors, including the vaccine itself, also the virus mutations, or the between vaccinations between, because one study or some studies said that if you provide between first injection and two injection only 2 weeks is not good compare in 1 month, something like that, or maybe more than 1 month is better to get a booster effect for the immunity. It meant that actually it's not like that too, because there's so many factors that immune response because behavior like smoking, alcohol, or maybe some nutritions, and also age group, and maybe comorbidity, and also different family size in the community, how they're living together, as also influence the immune response. The immune response is not easily calculated based on the study. It means that we should consider that how we can reach the herd immunity. Maybe herd immunity is not the best indicator as the success of vaccination. The success vaccination should be before that. It means that we should controlling the pandemic, and we can at least the declining of cases, severe cases, and declining the death, and then the cases will become not public health problem anymore. It means that this is the intermediate objective before we go to the herd immunity.
AJ, what's the talk in this sphere in India, where you've got so many people that to get enough people vaccinated is just enormously challenging?
Yeah, so I would like to say two things. The first is that leaving the vaccine out of the picture, the disease has moved into a remarkable fraction of the population in India. We have seroprevalence studies which show that in certain regions, so by July, August, September, there were certain regions where seroprevalence was at like 50%. And there are studies in the city of Bombay where amongst poor people, we were at seroprevalence rates like 80% about 3-4 months ago. So the disease moved into a very large part of the Indian population. In my opinion, other than rich people who were able to quarantine themselves into homes and manage a livelihood, for poor people, that was not a choice. So I think the disease really moved into the Indian population. Compared with that, we did not see a significant upsurge in hospitalization or death. So there are some features about the Indian environment, we don't know which they are, which have generated a relatively mild experience in terms of hospitalization and death associated with a large-scale spread of the disease in India. My colleagues and I have one paper on excess deaths in the pandemic. Unlike many other countries, you do not easily obtain mortality data in India. So we've had to resort to some complicated methods in order to estimate the mortality rate in India. And we find that there was an increase in excess deaths, but we just don't find the covariates which suggest COVID-19. We don't see that the excess deaths were amongst males, older, comorbidities, urban, all of which would have sounded like COVID-19 deaths. So this is the first point I'd like to make, that there's something about the Indian landscape and nobody as yet knows the answer. Could it be that there is something happening about the learning of the immune system? Could it be the fact that most houses have fairly good ventilation? Could it be the higher temperature? Okay, so we just don't know. We don't have a theory about why, but I feel that the evidence is by now clear that the scale of hospitalization and death associated with a pretty large scale spread of the disease was modest. The second thought I would like to offer this learned group is that I think we in public health should be thinking clearly and separating out two very different questions and very different phenomena. The first is the concept of a vaccine that is a personal benefit, that is a private good, that is akin to PPE. That's like buying a mask. Okay, so I'm a customer, I pay money, I buy a mask, the mask protects me. That's a personal conception of safety. Okay, that is one vision of a vaccine. And there is another vision of a vaccine, which is this is a part of public health. It's a treatment that's applied to the population. It is there to carry us along to herd immunity faster than would otherwise have been the case. And once you get to herd immunity, the differential equations do the rest, that the disease dynamics changes and the disease dies out. These are two very different visions of the world. And I feel all of us have been excessively conflating this. And then we get into this gossip on WhatsApp that my vaccine is better than your vaccine and so on. So I feel we should be steadfastly pushing a simple conception that if a vaccine is 52% or 51% effective, that's great, let's approve it. And let's just get more and more vaccination done in the country, because the graph that we've got to keep our eyes on is the number of people dying per day. Let's get that graph down, and it can be done in many different ways. We should not be pitching this excessively as a PPE.
Rona?
What was the original question?
I guess it's just comments about the different vaccines and the different potential goals that we have with the vaccines.
So I think there's over 200 vaccines in development, and we're going to see more and more vaccines with phase 3 clinical trials published and more data, and they will vary in efficacy. They'll also vary in safety. All of them so far are, don't have any serious side effects. They're safe vaccines. But there may be differences in, the types of local reactions and fever and so on following vaccination between different vaccines. We know at this stage the efficacy against symptomatic infection varies from somewhere around, against the regular strain from last year, around 63% to 95%. But it's close to 100% for severe infection, hospitalization and death. So I think it really depends on the country. In a country where there's a lot of COVID around, you want to prevent hospitalizations and deaths because that's what's going to overwhelm the health system and really stretch all the resources and put you into crisis mode. So if you think back to some of the severe first waves we saw in Europe and the US last year, where hospital systems were overwhelmed and dead bodies were piling up in refrigerator trucks outside, etc., that can all be avoided with any of these vaccines. So I guess it really depends on the context and what you want to achieve. But if you want to achieve herd immunity, then one of the issues is we can't vaccinate children as yet because the clinical trial data have not come out on children. We will have data on children, but at the moment, people under 16 years are not being vaccinated. So that immediately affects your herd immunity calculation. And you can mathematically calculate what percentage of the population needs to be vaccinated with a vaccine of X efficacy. But essentially, if the efficacy, and it's the efficacy, as you said, Karen, against any infection that matters. And I think it needs to be at least 70% against any infection. And then you'd need to have sort of 80% of your population vaccinated, which, if your population is a young population with a lot of children, that's going to be hard to achieve. But in an aging population like Australia, you still could achieve pretty high coverage rates in adults and come close to herd immunity with a high efficacy vaccine. It just has to be calculated individually. We don't know, of course, whether herd immunity is possible because of things like duration of immunity, etc. But we're already seeing data, for example, from Israel, data from the Pfizer vaccine suggests 92% efficacy against any infection. And you can certainly achieve herd immunity with that kind of vaccine. We don't know how long it'll last because there might be waning of immunity, but you know, booster doses and so on should be able to address that. Yeah, but Israel is a good example of a country that set out to achieve very high levels of vaccination very quickly with a high efficacy vaccine.
That's great perspective. And I'll ask Pandu first, but yeah, we've been talking about the challenges in rolling out, you know, the first wave of vaccines in each of our contexts. And if we fast forward, let's say to the end of 2021, and let's say we are all really successful and we get a large proportion of our communities vaccinated, then what? You know, public health people are going to be asked, now I've had the vaccine, now what? What does that allow me to do? And where do you see where do you see that's going to get us in for 2022 in terms of getting back to normal, opening up borders, travel, etc.?
Yeah, I think I made some simulation, you know, about the coverage of vaccination in Indonesia. If we focus on the big island like Java, at least we will get back to normal, or at least people stay happiness, still can easily have freedom is around next year. But if you want to do on the average, it's more difficult because we should because the problem is if we focus on the Java Islands, the 70% or maybe 60% people in Indonesia living there, it means outside Java will be protests about that, and we cannot do that. It means that at least the end of next year will be we will at least 70% of people will be vaccinated.
And AJ, what's the kind of forward thinking?
Yeah, the forward thinking is about the do we finish? No yet, because we just controlling.
Yeah.
We just controlling the pandemic, not yet eliminating it. And maybe because the virus is easily mutate, it means that maybe we still have another problem, the new virus, a new mutation virus, and also Dr. Raina said about how long the immunity long lasts. That's another problem that we should facing that I don't know yet about these situations because the current data is cannot answer all the problem we'll be facing in the future.
AJ, do you have a perspective? I mean, people often ask, is this going to become like the flu?
My opinion about how this is going is that at present in India, less than 1% of the population has been vaccinated. We are at a run rate of about 500,000 doses a day, which is just not a big number compared with the population of about 1.37 billion people. So 500,000 people every day is just not enough. However, what I think is going on is that the disease has spread amongst the masses. As I said, seroprevalence data shows that amongst poor people in Bombay, 80% of the people have antibodies. So in a way, you've got to herd immunity for poor people. The disease is spreading because the whole public health process that would try to interfere with community transmission did not really deliver. And the disease is just spreading. And luckily, just dumb luck, that we have not seen a great surge of hospitalization and death. What I do think is going on is that rich people have had the luxury of hiding in their houses and waiting for this storm to end. And the retreat by rich people from participating in normal social and economic life has exerted a significant adverse impact upon the economy and upon the livelihoods of everybody else in the economy. So vaccination is a very important economic milestone where the rich will get vaccinated and then step out into the world and start living normal lives. And that will bring back livelihoods to a lot of people who depend on the consumption expenditures of rich people. So I see the vaccination program as a path to economic recovery. And the game is about how to go up from 500,000 doses a day. And as I said earlier, that is all about retreating from a government domination and a government control to a much more market-based, private sector-led system.
Raina, when you talk to the public and think through where we might be in, by the end of this year or in 12 months from now, what's your predictions?
Yeah, I'm pretty optimistic, really. I think it's just phenomenal that in 12 months we've got vaccines, and so many good vaccines available around the world, and we're seeing vaccination programs already started. I think, there will continue to be hotspots of COVID, either because there are countries or parts of countries that don't have access to vaccines, or countries where there's a lot of vaccine anti-vaccination sentiment, such as the US. I mean, I think what we saw in the US with the masks and the protests about other public health measures like lockdowns may sort of tell us what's going to happen with vaccination, that they may not be able to achieve herd immunity in the US if they can't get their coverage rates high enough because there's so much anti-vaccination sentiment. I think eventually they'll get there, but there's a lot of work to be done to undo the damage that was done around confidence in public health measures and the kind of conspiracy theories and so on that were allowed to really take off there. So I think overall it's very positive. I think certainly for Australia and our region, it's very positive. But I think.
And do you think it's going to end up like the flu vaccine that will? I mean, you already.
I don't think it'll be annual, but it might be every 3 years, every 2 years. We don't know. There's not long enough follow-up to really know. But we may well need boosters.
Going to be a mixture of how much durability, but also how much if we are seeing vaccine strains. Yeah.
The effect of repeated doses may end up being quite critical in differentiating between vaccines, because there is some data suggesting, certainly with the adenovirus vector vaccines, that the response to the first dose, you get a higher efficacy than after the second dose. So that there's not enough data really. We need to watch and wait and see. But we know with other vaccines that sometimes multiple doses can kind of blunt the immune response. You see it with polysaccharide vaccines like meningococcal and pneumococcal polysaccharides, and the jury's a bit out on influenza, but there's certainly studies out there that show that multiple doses of flu vaccine blunts your immune response. So we don't know how that's going to pan out.
And we don't have the experience with the mRNA vaccines yet, so I guess. So I think this is a really good segue into one of the last things I wanted to discuss in the last few minutes before we move to some of the questions from the audience. But we clearly live in a global world where that interconnectedness and that the problems that we may have in not reaching control in one country are going to affect all of us. And the response that each country has had has been, the politicians and public health people need to protect their own communities, but we also live in this global interconnected world, and there's clearly been a lot of talk and actually also criticism about vaccine availability, costing, and equitability issues. So Pandu, have you got any comment on that? So really about how can we learn, what have been the problems with equitable vaccine distribution, and how can we, what can we learn from what's happened to make it better moving forward?
Yeah, the problem is about the stock of vaccine. It means that if the international like government or WHO or any global public health organizations can pursue the every manufacturer, local manufacturer, the vaccine manufacturer around the world, Indonesia, India, and many parts of the country can produce the vaccine. It means that we can reduce the gap between the demands of vaccine because the limiting of the manufacturer or because the problem of competitions, and we should have some agreements about the vaccines and agreement how we can manufacturing and also agreement to distribute around the world. And the important part of the solidarity, global health solidarity, is to be building by helping each other. And then the second, economically, the economic relief after this pandemic also should be getting together, because every country want to have to back to their prosperity goals. It means that SDG and many things that we already defined should be readjust to do the after this pandemic, because this pandemic is disrupt everything, and also the traveling among the country also become important to persuade the person to be vaccinated. It means that like in some Muslim rejection and anti-vaccines, finally they think about how can vaccinating themselves, because they cannot go pilgrim to the Mecca to go to Hajj, because the Arabic governments require the vaccinating should be done before they can go to the Hajj. It means that this is some solutions that related every country, local, and also helping another country how they can helping, and to everybody said there's no one safe until everybody's safe. How we can operationalize this concept to end this pandemic.
AJ, I know you have to leave soon, so I'll ask you what insights can you give us about how to improve the equitability globally?
So starting at India, it is ironic that 1 year into the social distancing, we have poor people where the disease has really been reasonably uncontrolled, and the rich have been hiding away in their houses. So the poor people have antibodies and the rich people need the vaccine. I just don't know how to think about this in the conventional concepts of equity. Playing on a global scale, I share what was said a moment ago. I feel strongly that we need to do much more in the global community to come together to be able to systematically track novel infectious disease developments that are happening all around the world, to be able to bring energy and passion into the development of treatments and vaccines, to be able to establish the real options of manufacturing capabilities all over the world, and prevent future outbreaks of vaccine nationalism.
And Raina, we have different issues here, and Australia, as you said, is part of the COVAX agreement. Do you want to just talk a little bit about that and see and give your thoughts on what our responsibility is, given that we don't have people infected, let alone dying?
Yeah. Well, I think in one sense, because we don't have the cost of the border closures and the life we've had to lead to achieve the COVID-free state is a huge cost. There's a huge economic and social cost. And I think the expectation of the community is that we can go back to relatively normal life with vaccinations. So, you know, it's not like there's been no cost. I think it's really important we acknowledge that to maintain this state of COVID-free life without mass vaccination is going to require enormous resources and have a cost for people when there's outbreaks and so on, and the whole hotel quarantine program and all the contact tracing, the case finding, all of that is very resource intensive. I think it is very much within the Australian plan to help our regional neighbours. In fact, the amount of vaccine that Australia has committed to is more than is required for the whole population. And my understanding is it is very much the intention, particularly to help in the Pacific, in the small Pacific islands and nations around us. So I think we will see that Australia will play a role in helping our regional neighbours.
And AJ, just before you leave, someone posted the question that you alluded to the fact that India is supplying vaccines to its neighbours, and yet, as you say, you know, only a small proportion of the population in India has actually been vaccinated. Is supply still part of the issue in India with that low rate of vaccination, or is it rollout and logistics?
The choke point is in the rollout, in the logistics. So if hypothetically you had infinite distribution, then no, there is not enough supply. But at present, we have you know, reasonably large amounts of supply coming out of particularly one firm, Serum Institute, which is a private firm in India, which is the world's largest maker of vaccines. So there's a fair amount of supply, and the bottleneck is in the distribution.
There's been a lot of Q&A going on, and Rona, thanks for answering a lot of it as we've been going through. But I think one of the things that you've answered in the chat that might be worth actually bringing up is the idea of vaccine passports and how likely it is we're going to move to that, what role WHO may play in that, and how that would or could be implemented.
So Karen, I think that's your area of expertise, isn't it? Karen's a leading expert in travel and infections. So, you know, I think we have a precedent with yellow fever vaccine. So I think it's, you know, not a big leap to add COVID vaccination. And I would fully expect to see that happening. In fact, many airlines are already saying they're going to require proof of vaccination. And I think it's very sensible. It reduces the risk for everyone if travellers are vaccinated, because travel is the way that infections spread around the world. I think ultimately in the end, it will matter what vaccine you've had, whether or not you have to go into quarantine. So if you've had a vaccine that has a very high efficacy in preventing any infection, then you may not need to go into quarantine. If you've had a vaccine that prevents death and hospitalization, but not as high efficacy in preventing infection, then you may have to have quarantine. So I'd imagine there might be some kind of tiered risk analysis eventually. It'll take a while to get there though.
That's interesting. And Pandu and AJ, when we talk about the different vaccines that are licensed, if we think about the possibility that there might be vaccine passports, would a vaccine that someone has had from overseas need to be licensed in your country for that vaccine passport to be recognised?
Yeah. We would love to discuss these questions further with you.
Yeah, it's very difficult, you know, which vaccine that to get approval for the transportations. It means another problem too, because some country doesn't approve, only consider they already have it. Maybe Sinovac cannot be approved by Australia, something like that. We don't know. We should have some agreement about these situations. All vaccine is the same condition for approval for getting enter the country. If I got Sinovac vaccine and I want to go to the Melbourne, can I should quarantine because they they don't approve Sinovac, something like that.
And AJ, do you have thoughts of how it may work and how logistically could we ensure that any vaccine certificate was true and legitimate? And
I can also see that it will be a privacy nightmare. That how are we going to keep the data safe? Because potentially the user of a vaccine passport will end up having to share data about their own location at many checkpoints. So I feel that there is a big need of computer science development of protocols whereby testing that a person has a vaccine passport is done in a way that shields that person's location information. Otherwise, we're going to have a privacy nightmare where this effectively becomes a tracing system to keep track of who has gone where.
Raina, I'm not sure you know what discussions are going on at WHO in this regards, and if you can shed any light, because I think WHO is planning, from what I understand, and will need to take the lead if we're going to get any global consensus or guidance on this.
Sorry, can you repeat that?
Sorry, I was just asking, if you know what and how WHO is trying to move this issue of global consensus on how to manage vaccine passports, legitimization, not making sure that privacy issues are maintained, etc.
Well, I think the yellow fever vaccination issue was kind of coordinated by WHO, but individual countries still require proof of vaccination. And I think it's something that probably falls under the international health regulations and is something that WHO will coordinate in the end. But I think there's other priorities at the moment that they're focused on. But I don't have inside knowledge on when they're planning to look at vaccine passports.
My understanding is that that they've set up specific groups to be looking at this, and it clearly is a topic of discussion, but it is really complex, and the different stages that we're at in different countries in terms of the epidemic itself and the crises, the public health crises that people are facing, as well as the vaccine rollout, make it so difficult. 6 months ago we were talking about proof of testing as the way of having been tested and tested negative as a way to perhaps enter countries safely, and there is still some testing going on, but then we know that tests are not all the same, and some tests are more sensitive than others, and the timing that the test is taken doesn't necessarily mean that the person isn't about to become infectious. So it is really a complex area. AJ, before you leave, if you've got time for one more question, there was a question posted about what do we think about removing intellectual property and allowing companies to produce vaccine freely?
It's a difficult question. We've got to look at it not just in terms of the here and now, but in terms of the long run consequences. It's a difficult market. There will be many vaccine candidates that will reach the market too late and will make losses because the price of vaccines is going to crash. Once a few vaccines reach scale, the price of vaccines is going to crash. So we should not underestimate the financing problem of getting the private sector to invest in the development of vaccines. So what I feel all of us can agree upon is that there needs to be more public expenditure on vaccine development. So to the extent that there is government funded R&D in this, and the results of this research are released into the public domain, I think there's absolutely no downside there. But intruding into intellectual property at the level of the drugs industry, at the level of the vaccines industry, I feel is more complicated, and we should think carefully about the long run consequences.
Okay, so I think we're running out of time, and I know that a couple of the panelists.
Would it be okay if I can drop off here?
Yeah, well, before you do, and I know Raina also has to go, so I just want to thank you all so much for this. I think it's really fascinating looking at this through the different lenses and seeing how we have a lot of the same problems, but also really unique different problems, and answering in one country is not necessarily going to give us, you know, the total answers. But I really appreciate your time and your perspective, and I can see from the engagement from the audience and all the questions that they have as well. So let me just thank you all, and to the audience, we hope you enjoyed today and found it informative.
Thanks a lot.
Thank you all.